I welcome all of you for the discussion of NEET SS 2025 recall of general surgery that happened on March 29th and 30th of 2025. So let's go ahead and look into the paper and we'll discuss the questions, and as and when you find anything opinion on the question and the options, you can type in the chat box. Most prominent muscle felt over the skin in the frog leg position. What is the frog leg position? Yes, adduction and flexion of hip and the knee. Frog leg position during gracilis muscle flap preparation is for what? Harvest of which muscle? The question is very simple. What do you think as an answer is? Is it rectus femoris or sartorius or adductor longus? So over the skin of the frog leg position, the answer is gracilis muscle itself. Okay. Gracilis muscle is used for the flaps as in Bailey and Love 28th edition, page number 550. In the frog leg position, supine with thighs abducted and knees flexed. The gracilis muscle is the most, see that the gracilis muscle is the most prominent muscle palpable over the skin. It is located medially on the thigh and is often used for the muscle flap procedures due to its size and vascularity. Because most of you answer this option C as adductor longus. But this is what the word to word exactly given in Bailey and Love 20th edition. Man, if this question appears to you is right and the options are the same, then according to the reference, the answer becomes gracilis muscle option D. Now, the floor is open for the discussion and you can give your views why you answer this C. Yeah, gracilis aspect is also in the medial aspect only. Gracilis muscle is in fact more medial than adductor longus. Have you heard of this? Sartorius, gracilis and semitendinosus, SGT. The medial most compartmental muscles are sartorius, gracilis and semitendinosus. They are attached to the medial aspect of the tibia, their attachment. There are three group of muscles, adductor group of muscles, I'll tell you. They are adductor longus, adductor magnus, and there is one more called adductor brevis. Is it okay? These are the adductor compartment of muscles. Then you have the next compartment of muscles. Yes, they are to intermediate to lateral. They are called vastus. Vastus group of muscles, vastus lateralis, vastus intermedialis and vastus medialis. And all these muscles, especially the vastus group of muscles, blend together and to form quadriceps femoris. And under that, it gets into ligamentum patellae. And then you have patella under that. And that is attached to tibial tuberosity. Tibial tuberosity. Okay. Do you remember, I was telling you that there is no surgery if you don't know anatomy. If you don't have an interest in anatomy, it's very difficult to have a great interest in surgery. Do you all agree? Now, could you imagine your first year of your MBBS that you have been taught? But this is the way of group of muscles arranged in the thigh. Yes. Then when you go on top on the femoral triangle, what are the muscles that forms the base of the femoral triangle? Iliacus, psoas and pectineus. Do you remember? Now you able to recollect? You will be able to recollect because this will be in your subconscious memory, in your cortex, to some extent in the permanent memory. Ilio, psoas, pectineus. Do you remember this? Yes? Yes. On top of it, on top of this muscle, what is there? Iliacus, psoas, ilio, psoas, pectineus. This, then on top of it, you have, what next you have on top of it? Downward prolongation of what? Fascia, iliaca. Then what do you have? Fascia transversalis. And fascia iliaca and fascia transversalis together is called what? Together is called what? What does it form? Those guys who are interested in vascular surgery, those people who are interested in plastic surgery. Yes? What is it? What is femoral sheath? Femoral sheath is formed by what? What are the contents in the femoral sheath? That is on top of this muscle, iliopsoas pectineus. What is the very idea of discussing this? Is this very idea of discussing this is to know the answer? Of course, yes. Know the answer. But what could be asked in the next exam is all about, right? Say yes or no? Yes? If yes, I am asking about the femoral sheath. How is the femoral sheath formed? Anteriorly by what? Posteriorly by what? This is my question. I am talking about femoral sheath. Anteriorly is a downward prolongation of fascia transversalis. Posterior layer is the downward prolongation of fascia iliacus. And the medialmost compartment will be empty. This will be empty. Yes, and this is the middle compartment. Vein. Okay, 3 compartments. And if 3 compartments, then this compartment should not be there. So, vein, artery and nerve. This is the femoral nerve. So, van, medial to lateral. Vein, artery and nerve. Nerve will be outside the sheath. Vein will be inside the sheath. Artery will be inside the sheath. And medial most compartment will be empty, and somebody said lymph node of Plockett or Rosenmuller. Okay. So, vein is packed within the femoral sheath. Actually, it's not supposed to be packed, because when you pack a vein within the sheath, it will get compressed, and that too, it is across the hip joint. You know what is the largest joint in the body? I'm asking you a question. What is the largest joint in the body? Yes, before the exams or after the exam, the enthusiasm is the same and the energy is the same, because we are in the continuous learning process. You understand what I say? Yes. So, the largest and the most complex joint in the body is what? Is the knee joint. Of course, hip is one of the major joints. So, when a structure has to pass across the hip joint, it has to be protected. It has to be protected, so it's packed well within. Once it has been packed well within, then the God understood that we are packed in a structure which has to expand, because blood has to flow from the leg to the heart. Then what he did? He made one shift. Yes. This arrangement is by a mistake. God's own mistake. Initially, when he did an architecture of packing in the body, he was little overprotective to pack the femoral vein within a sheath. Then he understood, okay, by mistake we did it. So, we need to make some adjustment. For that adjustment, what he did? God moved the nerve outside and kept the artery in the lateral compartment and the vein in the middle compartment, and he kept the empty space. The node is just a MCQ. There is nothing there. He kept the medialmost compartment empty, so that when the vein has to expand, it will have a space to expand in the medialmost compartment, which is empty. Now, you understand what I say? So, God did a mistake and he did a correction. You able to appreciate this? This is a huge mistake. You can ask me, sir, how do you say it's a huge mistake? Do you have any substantiating evidence to prove it's a huge mistake? You ask me this question. And an adjustment done by God. How do you know that? I know it. Because I understood what God did to us. It is not through literature. It is through the feel of the subject and going through the subject. Can I tell you that? You want to hear that? How I understood what was in the God's mind in the creation. Should I tell you that? How mistake was happened and how I recognize this mistake. I want your quicker response if you're interested to know that. It is not about just learning. It has to be learned. It has to be learnt. In a way, it has to be learnt. It's such a beauty. The human body is such a beauty. I thoroughly love this subject. I'll tell you, for your information, This is the axillary sheath. What is this called? Axillary sheath. You know, how is axillary sheath formed? You know that? Axillary sheath is formed by the continuation of prevertebral fascia. What fascia? Prevertebral fascia from the neck. It continues into the axilla. Now, when you look at there, what are there within the axillary sheath? The structures which are there in the axillary sheath are axillary artery and the brachial plexus. Medial cord, lateral cord and the posterior cord. Brachial plexus. So, medial, lateral and the posterior cord of the brachial plexus. Now, if you ask me where is the vein, vein will be kept outside. It has to be kept outside because it has to expand. So, vein will be kept outside. So, axillary vein outside. And the axillary artery and the nerve inside. This is the correct arrangement. Because artery can expand and can contract. Nerve should be packed safely. Yes, nerve should be packed safely. It's very important to be packed safely inside. It can't be opened. This is the appropriate and right arrangement. And the vein has to be superficial to expand. Say yes or no, do you agree? So, is this a logic? Is there a correct arrangement here? Because vein you put it inside a sheath, it will get compressed. So, in the upper limb, he did right. God did right to us. Perfect. The nerve important from the neck, it comes down and it is going into the sheath. Artery, yes, it can. It will be inside, but vein you can't keep it inside. Say yes or no, this is the right arrangement. What he felt, because the locomotion, because the movement of sitting or standing or walking, everything has to do with the hip joint. Now, every time we don't use our hand. If at all we want to use, he kept an unstable shoulder joint. See, he kept, how do you understand? See how beautiful, see the beauty of it. See, he kept an acetabulum like this, even deeper than this, acetabulum, and he kept the ball inside. He kept the ball, head of femur. So, stable. He won't keep that joint as a stable. And a strong ligament, iliofemoral ligament, ligament of Vigilo, ischiofemoral ligament, all strong ligaments. Dislocation is very unlikely. And for shoulder, he kept a shallow glenoid and a open head of humerus. Open. The head of humerus is open. Just blunt it is. And then he said, rotator cuff to stabilize it. In case it has to get dislocated, let it get dislocated. The most commonly dislocatable joint in the body is shoulder joint. And the most important structure to stabilize is not the bony structure, it is the labrum. Labrum, and there is the rotator cuff. Say so or no? So, if at all has to dislocate, let's try to get dislocated, but this three structure has to be protected at any eventuality. So, it's a perfect package. The importance was given to the artery and the nerve there. And the vein was kept outside to expand and this to be protected, and anything, the joint is kept at stake, but joint in the hip is kept perfect, and he felt the most important for cardiac output, the venous return of the lower limb, and that has to go safe. It should not be any problem. And he beautifully packed inside. And then once he packed, he understood the mistake that has to expand. Then he kept the medial most compartment empty. Then he moved one frame shift he did. From the medial most, he kept the vein in the middle, then the artery lateral, and the nerve to be pushed out. Is it okay? And he felt, it's only femoral now, so what? The most important nerve in the lower limb is sciatic nerve. Let it not come through lesser sciatic foramen under the cover of piriformis, let it go between the hamstrings safely and go to the popliteal fossa and divide it into the anterior tibial nerve and the posterior tibial nerve. So, he met that way. Yes? So, whatever it has to supply, it is going to supply the vastus group of muscles. Correct? Sartorius, rectus femoris. Yes? Quadriceps femoris. I said rectus femoris. The amalgamation of this muscle, I think subconsciously some trigger happen that this is not rectus femoris is a muscle by itself. This condensation of this muscle, you didn't correct me also. This is called quadriceps femoris. Quadriceps femoris. There is one more muscle in the back of the thigh. It's called quadratus femoris. This is quadriceps. Yes, that in turn to ligamentum patellae and then into attachment of tibial tuberosity. Is it all okay for you? Hello, have you all understood? Anybody is going to ask you tomorrow about the shoulder joint or the hip joint or the arrangement of structures. Yes, you should go in depth and to tell them. The longest cutaneous nerve in the body is saphenous nerve. The saphenous nerve accompanies the long saphenous vein, and that is a branch of the posterior cutaneous division of femoral nerve. Can you tell this? What did I tell you? What did I tell you? Saphenous nerve. I told you something about saphenous nerve. 2 MCQs I told you about saphenous nerve. Long saphenous nerve. It's a continuous acquisition of knowledge. You have all completed your exams. Yes? And you will get a good rank. No doubt about it. You will get a good college. And even then now you want to learn, right? That's the beauty of it. The learning has to be continuous. It is not that this question, this answer. I am not here to do that. Longest cutaneous nerve in the body is saphenous nerve. What is the thickest cutaneous nerve in the body? Can you tell me? Thickest cutaneous nerve in the body. Sciatic nerve is the largest and the thickest nerve, sir. Sciatic nerve is the largest and thickest nerve in the body. I am saying thickest cutaneous nerve in the body. I said longest cutaneous nerve is saphenous nerve, and saphenous nerve is a branch of posterior cutaneous division of femoral nerve, saphenous nerve. Can you tell me the thickest cutaneous nerve in the body? It is there in the neck. There is something called suboccipital triangle. Have you heard of this? Suboccipital triangle. And in suboccipital triangle, this is one of the content, along with the vertebral artery. You want the answer? If you want the answer, I'll tell you the answer. The right answer is, the thickest cutaneous nerve of the body is greater occipital nerve. What is the answer? Greater occipital nerve. The longest cutaneous nerve in the body is a saphenous nerve. The thickest cutaneous nerve in the body is greater occipital nerve. And greater occipital nerve is one of the important content of suboccipital triangle, along with third part of vertebral artery. Which part of vertebral artery? Third part of vertebral artery is becoming fourth part as it goes into foramen magnum. Yes? Okay. The longest cranial nerve is vagus. Longest cranial nerve in the vagus. Okay. Is this all okay? Have you all understood all about this? See, the gracilis muscle is one of the most important muscles that is used for treatment of incontinence. The gracilis muscle is wrapped around the anus to reinforce the anal sphincters, and when you electrically stimulate, this is called dynamic gracilioplasty. It is called dynamic gracilioplasty. Is it okay? Okay, let's move on to the next. A patient was diagnosed to have an invasive ductal breast cancer. How will you counsel the patient? The patient has been diagnosed. The patient comes with a breast lump, and then you take a biopsy. Okay? Then once you take a biopsy, it is proven to be a breast cancer of a variety of invasive ductal carcinoma. Correct? What is the answer here? When you have to get a consent, how do you get a consent? You can type your answer. Yes, the right answer is, you need to counsel both the patient and the relative together. Where is it given? Sublisted 21st edition. 22nd edition is going to come. We are going to start the class on 22nd edition shortly. It is ethical and beneficial to involve both the patient and their family members in discussion about the diagnosis and the treatment options. This ensures the patient receives support and that family members are informed which can aid in the decision making and emotional support. Correct? So both have to be informed and consent has to be from the both. Now you should at the same time you should also understand that they'll always ask you about the triple assessment. In the management of breast cancer, the triple assessment is all about clinical examination, The next is radiological examination, and the next is pathological examination. So clinically, if you see a lump or any signs of a breast cancer, and radiologically it is also proven, that is evidence, either it could be an ultrasound, yes, or in cases of an MRI, or even a screening mammography, any radiological evidence. And when you do an FNAC or a true cut biopsy or excision biopsy, and a pathological diagnosis is made. So the initial investigation of choice they'll always ask you is FNAC, and if FNAC is inconclusive, the next best will be a true cut biopsy, and investigation of choice to confirm the diagnosis. If this is also inconclusive and true cut is also inconclusive, then confirmatory diagnosis will be excision biopsy. So consent has to be obtained from both the patient and the attender. Is it okay? That is a relative. As per 21st edition of Submission 567. Next question. You are doing a lap cholecystectomy. While doing the surgery, portal vein got injured and lot of blood loss occurred, but you are able to control the bleeding and injury was repaired. How will you counsel the patient? So eventuality happened during intraoperative procedure, and how will you counsel the patient and how will you describe the event to them? How will you explain this to them? Okay, the right answer for this is option B. Don't tell everything, just tell the injury occurred during the surgery but it was managed successfully, because it is over. You need not scare them, you need not think about them to cause more distress to them. Where is it given? It is given in 11th edition of Schwartz. They have kept all the questions, 150 questions within these 3 books that I can tell you. Schwartz 11th edition, page number 789. While full disclosure is important, the level of detail should be appropriate to the patient's emotional status and understanding. Informing the patient that an injury occurred but was successfully managed helps to maintain the trust without causing unnecessary distress. Are you able to understand the importance of doing our discussion word by word? Is it not lifted from anywhere? It was lifted word to word from standard 3 textbooks. I'll tell you one thing. I have not picked up any of the explanation from the book. I have just picked, cut, copy, paste from our PPTs for all the questions. It is from word to word, line to line. For all the 3 questions, it is word to word, line to line from all 3 books. Okay, let's move on to the next question. Last sign came in the compartment syndrome. This we discussed in high yield also, just before the exams. Hope you remember, but anyway, it's an easy question only. Last sign came in the compartment syndrome. The right answer for this question is paralysis. Yes. Bailey and Love 28th edition very clearly says 354 page number, the compartment syndrome, the sequence of signs typically progresses from pain, number 1, pallor, paresthesia to paralysis, which is last. He very clearly says paralysis is the late sign, an indicative of irreversible nerve damage. Oh, what more you want? Okay, one more option is pulselessness. That's okay, accepted. But doesn't make a difference for change of an answer here. It's very, very clear. Yes? So compartmental syndrome is very, very important. Any compartmental pressure more than? What is diagnostic? Any compartmental pressure, tell me first, more than. I want you to type. More than? I give you options. 20, B, 30, C, 35, D, 40. More than what is diagnostic of compartmental syndrome? Yes? The right answer for this question is? All of you? More than 30. It has to be more than 30. Is suspicion and diagnostic of compartmental syndrome. Okay? Compartmental syndrome of the leg, because you have one more compartmental syndrome called abdominal compartmental syndrome. Yes, do you understand? Yes, you should be very careful of that. Patient was diagnosed of anal carcinoma. HPE shows squamous cell carcinoma. What is the treatment of choice? It's a very, very clear-cut case. Yes, it's a very, very simple and a straightforward question. We have discussed n number of times in the class, and it is a chemoradiation. It is called Negro's regimen. What regimen? Negro's regimen. Alternate chemotherapy and radiotherapy. Yes. So, mitomycin and 5-FU based first line and cisplatin. Chemoradiotherapy is called Negro's regimen. Negro's regimen. Understood? Chemoradiotherapy. Squamous cell carcinoma. Yes, of anal canal. So, today this is the regimen, and 21st edition of Subsystem 1345 very clearly says anal carcinoma, especially squamous cell carcinoma, chemoradiotherapy is a standard of treatment. This approach combines chemotherapy with radiation therapy to improve the local control and the survival rates. Very, very clear and a straightforward question. A child falls from the bed, an active eye opening. See, active eye opening, and is irritable and crying and is showing withdrawal of limb. Without GCS, there will not be any paper. I have told you n number of times in the class itself, and we have discussed in every paper of our high yield. GCS is a must question. Shock is a must question. Wound is a must question. This is a must question. GCS and scores of GCS. Child puke Turcot score. All scores, of all the scores, you will get minimum of 5 to 6 questions. What is the answer? So, the right answer is 14. How do we get 14? See, based on the pediatric GCS scoring system, the child would receive eye opening number 4 spontaneous, verbal response number 5 cries to pain, motor response withdraws to pain. So, totally you get number of 14. You can get for adult also, pediatric also. So, 11th edition of Schwartz, page number 1123, very, very clear GCS. So, based on GCS, you will classify them into a mild, moderate and severe head trauma, correct? Based on that, you will plan the treatment. Yes. So, you know that for mild head injury, yes, a simple observation and discharge on the same day. Okay, when there is an attender. Number 2, moderate head injury, you need to take a CT scan. Based on the CT scan finding and clinical examination, you will plan for admission and further treatment. And for a severe head injury, yes, you need to do neuroimaging. Whether it is a CT scan or MRI, neuro ICU, and management based on finding. So, treatment as per finding of neuroimaging and clinical presentation. Understood? So, very clear protocols. Pseudo kidney sign. Where do you get a pseudo kidney sign? Very simple question and straightforward question. Answer is intussusception. The most common type of intussusception is what? Ileocolic. And the average time period, the most common type and the average time period, yes, most common time period is what? 9 to 12 months. That is after period of weaning, because exclusive breastfeeding is for 6 months. So, at that time, it doesn't occur. After you start the foods, artificial foods, then Peyer's patches hypertrophy happens and that becomes a lead point, and that aids in the prolapse of the subsequent mucosa, submucosa and the layer of the bowel into the cecum, and then moves on. So, ileocolic is one of the most common type of intussusception. Understood? Colocolic, they will ask you. Colocolic intussusception is seen in whom? The colocolic intussusception is more commonly seen in adults. Ileocolic more commonly seen in children. Okay? Okay. So, Subsystem 21st edition says 678. The pseudo kidney sign on the imaging is characteristics of intussusception, where a segment of bowel telescopes into the adjacent segment, creating a mass, and that resembles the kidney. So, you know, there is a layer which goes inside and the layer which is outside. So, the layer which is outside is called intussusceptions, and the layer which goes inside is called intussusceptum, and this will be the apex and this will be the neck. You understand? So, whenever you have to reduce this intussusception, yes, and the intussusception management protocol could be conservative. So, the conservative management could be air, saline, barium to reduce. But you don't do conservative method 1 if there is a sign of perforation. If there is any sign of perforation, rigidity guarding, don't do it. And if it is not possible, if it is failed, then go to surgery. The most important technique is squeeze technique. You need to, into recipients, that the recipients, that you need to gently squeeze, and so that the susceptible layer which goes inside, which is gone inside, will smoothly will come out. Okay, don't pull it because it can cause more trauma and injury. And in case, if it is gangrenous, the entire segment is gangrenous, do a resection and anastomosis. If anastomosis is not possible, resection and exteriorization. Then anastomosis after 6 months or 6 weeks. First 6 weeks, if you can reconnect, it's okay, or you can wait a little more than that, but maximum within 6 months, it has to be closed. Okay, so this is about intussusception, and you have beautiful signs. In intussusception is most commonly asked, or about the sausage-shaped mask, and you also call pincer sign, pincer grasp sign. Okay, pincer grasp sign, and sign dance, and red currant jelly stools. See how the brain works. It goes what all they can ask, how they can ask. These are the things they will expect. These are the things they will expect. This should be what is running in your mind. And next exam, even they ask intussusception, all this should come in, all these data. Yes? Okay, while iotography, the multiple side hole tube is placed at the level of diaphragm to delineate what? Okay? See, every question you will understand that it starts with anatomy. Yes? So, always you have to perform at an extraordinary level. Yes, not an average level, world class. It should be always world class. Yes, the way you learn and the way you deliver always has to be world class. And to remember for life. See, there are 3 ventral branches of aorta. What are the 3 ventral branches of aorta? Celiac axis, yes, T12, L1, superior mesenteric artery, and L3, inferior mesenteric artery, correct? So, diaphragm, the roof of the aortic hiatus. The roof of aortic hiatus is formed by the diaphragm, diaphragmatic opening. And you know what forms the roof of the aortic hiatus in the diaphragm? Yes, you know what it is? Median arcuate ligament. Yes? You can ask me, sir, can you tell me a little more? I will tell you. Lateral arcuate ligament, medial arcuate ligament, and median arcuate ligament. Again, medial arcuate ligament and lateral arcuate ligament. Now I will draw diaphragm for you. This is the diaphragm. Now what I have drawn is the inferior surface of the diaphragm. So I will tell you, this is lateral, this is medial, this is median, and this is medial, and this is lateral. So this is the inferior aspect of the diaphragm. And this is the median. So 2 medial will join to form median. And the floor is formed by the vertebra. What vertebra? T12 vertebra. Yes or no? Is it okay? Now you will see inside this, you see the aorta and the origin of celiac axis. So the compression of the median arcuate ligament on the celiac axis, on the aorta, on the T12 is called median arcuate ligament syndrome, or otherwise called celiac artery compression syndrome. Do you understand what I say? Say yes or no? Are you all appreciating how the examiner is asking you a question? Is he asking you a question on anatomy or on a surgery? Was the surgical exam, are they asking you a question on anatomy or surgery? Yes, it's a surgical question. Now, all the questions that I have discussed have a strong base on anatomy. Basics are not strong. You can never appreciate this subject. And it's very difficult to appreciate and give results to the patients. Please understand this. A faculty has to be really strong in this anatomy. You should know where, and how. You should bring the subject from there. So then you can appreciate that. Yes, do you all agree? Are you able to appreciate? So are we all moving for every question from the basics? Yes, and to build concept on that and get on to the surgical aspect? Yes or no? If I just teach you something this way, in what difference it makes in learning? No difference. That you can do by yourself. There are plenty of videos available on YouTube today. Yes or no? I am the last to do it. I am the last to do it. Yes? But this is the way we do it. So, we should make an attempt to learn our anatomy very well. You get it from my today's class today. Yes? Those who are attending the class today. And those who are going to see this video. That if you love surgery, you should love anatomy. If you don't love anatomy, create a love for anatomy. And then you'll be a great surgeon. So, superior mesenteric artery, inferior mesenteric artery. Wilkie syndrome, compression of Wilkie syndrome or superior mesenteric artery compression syndrome against the third part of duodenum. Third part of duodenum. Third part of duodenum will be compressed by superior mesenteric artery against the aorta, arterial angle. Okay. This is called Wilkie syndrome. Okay. Now, 11th edition of Schwartz 1345, multiple side holes tubes are used during aortography to delineate the celiac artery, which arises from the aorta at the level of diaphragm. This technique ensures the clear and detailed imaging of the artery. How it is? See the question, see the explanation in Schwartz. In the master class this time I did in detail on Schwartz. 1.5 years I was taking the class for master class. Word to word, sir. You appreciate now. Word to word. See that. If this question appeared in the exam, this was the question of the architecture of the question, and this is the architecture of the text which is available in the standard textbook. If it is yes, you say yes. If it is no, you say no. Because I have not written the exam. You are given the exam, you are given the question to me. I am just telling you this is from the book. Okay. Now people ask me, sir, why are you doing this way? Why are you taking MCQs this way? Why are you taking such details, minute details in the class? Because I had a reason to do that. All the 3 books I went. I'll tell you, with extreme difficulty and the extreme effort, that 1.5 years of class was put up because the exam was delayed. I was taking class till the last week of the exam. And a sincere effort was made to crack as many paragraphs and lines from these 3 standard textbooks without much of overlap. So that it could enable the student to crack this exam at higher scores. While doing pancreatic transplant, what back table preparation was done? This we did in pancreatic transplant. Hope you would have remembered my class that day of pancreatic transplant. Even still it is available in the app. You kindly go ahead and see. We are talking about something called the same diagram I have drawn. This is called bench dissection. See, in the entire pancreatic transplant, let me give you the answer first, then I'll explain. Splenectomy. See, the indication for pancreatic transplant. The indication of pancreatic transplant, a patient who is diabetic and he has nephropathy. So, it's a diabetic nephropathy induced chronic renal failure and he has gone to end stage, ESRD, end stage renal disease, and he needs a transplant, indication for transplant. This is the indication for pancreatic transplant. In a pancreatic transplant, it is pancreas and the kidney transplanted together because that's the concept here. If you want to do only to treat for diabetes, you can do only islet transplant. Today, you don't do a whole pancreatic exocrine transplant. You do an islet transplant alone. Is it clear? Now, when you do this, what happens is, what you need to understand here is, the blood supply of the pancreas and the head of pancreas, especially head of pancreas, and the blood supply of the C loop of duodenum is the same. It is supplied with the superior and the inferior pancreaticoduodenal artery. Superior pancreaticoduodenal artery and the inferior pancreaticoduodenal artery. Is it clear? Now, what you need to understand is, I'll just tell you very important this is. When I said superior pancreaticoduodenal artery and I said the inferior pancreaticoduodenal artery. The superior pancreaticoduodenal artery is a branch of gastroduodenal artery. The inferior pancreaticoduodenal artery is a branch of superior mesenteric artery. So, superior pancreaticoduodenal artery arises from gastroduodenal and the inferior pancreaticoduodenal artery arises from superior mesenteric artery, the first branch of superior mesenteric artery. Inferior pancreaticoduodenal artery. Inferior pancreaticoduodenal artery. Now, this supplies the anterior and the posterior aspect or the superior and inferior aspect of the head of pancreas and the C loop of duodenum. Same blood supply. So, you can't remove duodenum alone or head of pancreas. Both has to go. So, if both goes, it's called pancreaticoduodenectomy. And this is called Whipple's procedure. This applies to all the Whipple's understanding. Whipple's procedure. Now, what you need to understand here is when you do both exocrine and endocrine, this is what exocrine and endocrine together. When you do a pancreatic SPK, simultaneous pancreatic kidney transplant, it is both the exocrine and endocrine pancreas. Now, what happens is the endocrine part of the pancreas, the islets, the number of islets, the more number of islets are located in the tail of pancreas. But the tail of pancreas is located within the hilum of the spleen, within the lienorenal ligament. What ligament? Lienorenal ligament. Lienorenal ligament. Along with the splenic artery and the splenic vein. So, what happens is you have to remove with the C loop of duodenum with the entire pancreas along with the spleen. Now, what do you take it into the bench? Now, what you do is you will trim whatever you want in the duodenum, put a stapler, and then you cut this spleen into pieces without touching. See that? Without touching the tail of pancreas. Don't touch the tail. No touch technique. No touch. And then with the superior mesenteric artery and the splenic artery, you make a Y connection for the arterial input and the venous output, the superior mesenteric and the splenic vein. So, you get a Y graft done arterially, then you attach that to the external iliac or internal iliac artery or vein. And then if you want to do two type of drainages are there. One is a bladder drainage, and the other is the enteric drainage. Okay, enteric drainage will be more anatomical and bladder drainage is extra anatomical but easy to monitor. You are able to measure the urinary amylase or lipase, so easy to monitor. Here, this is anatomical, but what you need to understand is external enteric drainage for monitoring the graft. You need to use serum creatinine level to see the graft acceptance or rejections. And for bladder drainage, you will be able to monitor the pancreatic enzymes. So, you will be able to do the pancreatic side and also you will measure the serum creatinine and urea. Yes, but in enteric drainage, you will be able to only see the renal side, not on the enteric drainage, you will be able to see only on the renal side, not on the pancreatic side. So, that is the advantage and disadvantage of doing enteric drainage and the bladder drainage. Is it all okay? So, 28th edition of Bailey and Lowe says 1621. During a pancreatic transplant, splenectomy is often performed to prevent immunological complications and improve the graft survival. The pancreas is typically anastomosed to the duodenum and the splenic artery is ligated. Okay. Patient has an absence pectoralis muscle with syndactyly. It's a very famous question and a simple question, and this has been discussed along in breast cancer in our class, during our class. Discussion of breast anatomy, embryological abnormalities. Answer is Poland syndrome, absence of pectoralis muscle and brachysyndactyly. It's called brachysyndactyly, Poland syndrome, and costochondral chest defects and rib defects and hypoplasia of the subcutaneous tissues on the affected side. Yes, Poland syndrome. And very clearly says Bailey and Lowe, 20th edition, page number 1191. Poland syndrome is characterized by congenital absence of pectoralis major muscle on one side of the body and often accompanied by syndactyly, fusion of fingers or toes. Okay, and also affected the chest wall hypoplasia on that side. Now, identify, this is a picture test. Identify what is given. So, it's very clear cut case of what? The clear cut case of extrophy with epispadiasis. And extrophy, epispadiasis is mostly associated with extrophy, epispadiasis complex. And often they ask you this. And extrophy of the bladder is the exposure of the bladder wall or the absence of anterior wall of the bladder. And there's always, you need to know that they always ask you difference between hypospadiasis and epispadiasis. Okay. And hypospadiasis and epispadiasis and the differences and abnormalities. Curvature. Curvature in hypospadiasis will be ventral. And chordae will be ventral. Ectopic opening of the urethra will be ventral. And the hood will be dorsal, where the hood in epispadiasis will be ventral. And when you look into the curvature in epispadiasis will be dorsal. Chordae, dorsal. Urethra, ectopic urethral opening, dorsal. And epispadiasis associated with extrophy of the bladder. And they can be associated with bifid pelvis, widened pelvis. Bifid. And waddling gait. And long run, they are associated, VUR, vesiculated reflex. Long run, they are associated with adenocarcinoma of the bladder. Is it all okay? Yeah. There we go. So, extrophy epispadiasis is a complex spectrum of congenital abnormalities varying from degrees of anterior abdominal wall defect and genitourinary defect. The bladder is everted and exposed to the exterior, and continence mechanisms are deficient. And exposed bladder wall, the lower abdominal wall, widened genitalia, and epispadiasis urethral opening in the dorsal aspect rather than the ventral as in hypospadiasis. And separated pubic bones are typically present. Okay. Next question. A patient has an alopecia of 12 into 6 cm over the scalp following a surgery and split thickness, the skin graft. What can be done to treat alopecia? What can be done? The best answer for this is a tissue expansion. The best is tissue expansion. It's a plastic surgery question. Bainey and Love, 20th edition, page number 681 very clearly says, the tissue expansion involves the gradual stretching, okay, gradual stretching of the scalp skin to create an abdominal additional tissue, which can then be used to cover the areas of alopecia. This technique is particularly useful for reconstructing defects resulting from surgery. Okay, tissue expansion technique. And you have known that expansion of spaces, yes, especially in laparoscopic hernia surgeries. Laparoscopic hernia surgeries, especially extraperitoneal approach. Extraperitoneal approach. Okay. So, between the transversalis fascias and the muscle, anterabdominal muscles, external oblique, internal oblique, transverse abdominis, you create a space and to keep a mesh. Say, and even used for laparoscopic renal exploration. Use tissue expanders to create the space between the retroperitoneum and the kidney. So, once you create the space, then you can do pyelolithotomy, nephrectomy and all those procedures. Okay. So, there are certain areas you need to expand the space for you to get the space to do it. Even in SEPS, you need some space to subfacial endoscopic perforator surgery. You need a space for you to clip the perforators, right? The perforator which connects from the superficial system to the deep system. Okay. Yeah. There we go. Indication for thoracotomy. There are multiple indications for thoracotomy. Among this, based on the output, what is the indication? The right answer is 1500 ml of output in a chest tube is an indication. A chest tube output, page number 446 in 20th edition of Bailey. A chest tube output of more than 1500 ml initially or persistent bleeding more than 200 ml per hour for 3 hours. After trauma indicates a need for thoracotomy to control the bleeding and access injuries. This is the output. Now, other than that, any injury to major structures like aorta, trachea, bronchus, yes, you have to explore heart, lungs, you have to explore. Major laceration of the lungs, or you see a bony structure goes with every breath into the lung parenchyma. Of course, there will be a pneumothorax along with that. Hydropneumothorax, hemopneumothorax. Yeah, penetrating injury only most often causes continuous and increased amount of blood in the pleural cavity. Usually blunt trauma can also, I am not saying no, but mostly it will be restrictive, not be progressive. Monad sign. Monad sign is seen where? Which pathology? The right answer for this, the monad sign, is aspergilloma. Aspergilloma, as it exactly given in Bailey and Lau, 28th edition, page number 974. Monad sign referred to the specific radiological appearance associated with aspergilloma of the lungs, characterized by well-defined round lesion with a surrounding zone of consolidation. Okay, even aspergilloma, there could be a cavity in the lung, and within the cavity there could be aspergillus ball. Aspergillus ball. In a long run tuberculous cavity, it can develop an aspergillus ball. Or surrounding consolidation, there could be aspergilloma, a ball effect can be seen. Okay, very good, excellent. A patient had a blunt chest trauma, decreased left side air entry with shifted trachea mediastinum, distended neck veins. What to be done? So, blunt chest injury, I think it could be a pneumothorax, and there is a tracheal shift, mediastinal shift. Yes, the right answer should be first. And typically a case could be of a tension pneumothorax. Put a wide bore needle in the second intercostal space towards the apex, then put the tube thoracostomy in the triangle of safety. And triangle of safety, all of you know that, anteriorly formed by the pectoralis major muscle and posteriorly formed by the latissimus dorsi muscle and inferiorly by the fifth rib. Understood? And you will go most probably in the mid-axillary line. Triangle of safety. So, needle decompression first, life saving, then tube thoracostomy. So, Bailey and Lau 20th edition very clearly says 446. You can use as big as possible, 18 gauge, anything wide bore needle. Yeah, 18 gauge can also be used. These signs suggest a tension pneumothorax and immediate needle decompression followed by tube thoracostomy in the standard management to relieve the pressure and prevent cardiovascular collapse. Okay, patient cough, foul smelling sputum, chest x-rays, shows a cavitating lesion. So, there is a cavity. So, a cavitating lesion. So, it's a typical case of a lung abscess, and the lung abscess treated antibiotic. If lung abscess ruptures, it can cause empyema of the thorax. Empyema of the thorax. If it opens into the skin, overlying skin, then it is called empyema necessitans. Empyema necessitans. And then it eventually becomes a bronchopleural fistula. Empyema necessitans, bronchopleural fistula. Okay, the most common cause of empyema is pneumonia. Okay, very clear. So, lung abscess, 20th edition of Bailey, page number 974. The lung abscess presents with the symptoms like productive cough with the foul smelling sputum and radiological finding of a cavitated lesion, often in the left lung. Okay, name of the valve in the picture. So, it's a semilunar valve. You have three cusps, and the semilunar valves are either seen in where? Either as a pulmonary valve or an aortic valve. And how do you know it's an aortic valve? In an aortic valve, what is that you see? You see the coronary sinus. Okay. Opening of what? Coronary ostia. Yes, the sinus of Valsalva. Yes or no? So, it's going to be an aortic valve. Okay, right and left coronary sinus. Aortic valve is a semilunar valve, and right and left are non-coronary. Each cusps are associated with the sinus of Valsalva, and the valve opens during systole and closes during diastole to prevent regurgitation. Aortic valve. Now, today, the most of the aortic valve surgeries are avoided and most of them are treated by TAVI, TAVI. Okay, trans-aortic valvular implantation. So, through a Seldinger techniques, a femoral approach, and a self-expanding metallic valve, yes, is passed across the deceased aortic valve and balloon with a balloon opening, and then you implant the valve and you open up, then it automatically expands, and you will calculate the BMI of the patient, and you will calculate the aortic orifice, and you will size accordingly, and then you will choose an appropriate valve to implant. So, the patient goes home 1 or 2 days later after the observation, and he can avoid an AVR, aortic valve. Understood? It's called TAVI. Okay. Brown-Sequard syndrome is due to. Okay. So, which of the pathology can cause Brown-Sequard syndrome? So, the Brown-Sequard syndrome is seen in an intramedullary tumor. Now, Brown-Sequard syndrome, page number 702, 20th edition, is a hemisection or damage to one of the side of the spinal cord. It can be often due to intramedullary tumor. See how, was the question asked in the same way? You need to recollect it. Leading to motor and sensory deficits on the same side. Okay, ipsilateral, motor and sensory, and contralateral pain and temperature. Okay, ipsilateral, motor sensory, contralateral, pain and temperature. This is Brown-Sequard, correct? This way you remember, right? Ipsilateral, contralateral. Was the question asked in the same way? Was an intramedullary in your option? Yes, the same word it is given in Bailey. Same word. Okay. So, pre-pneumonectomy, post-pneumonectomy X-rays are shown. Comment on this. Again, this is from Bailey only. So, there's a pre-pneumonectomy and post-pneumonectomy. So, it very clearly says there is a hemothorax. This is classically a hemothorax, and this is only hemothorax, and this picture shows hemopneumothorax. There is air on top. Okay. So, either B or D, depending on the picture what you got. If the same picture is there, if this picture, then it is hemopneumothorax. Here there is little air, but predominantly hemothorax. Depending on that, either you answer as hemopneumothorax or hemothorax if air and fluid is there. Because why blood? I think then you go for hemopneumothorax if 3 is there. There we go. Okay, the answer is hemopneumothorax. Now, after pneumonectomy, there is something called space management. They'll ask you this. How do you space manage? One of the most common technique, there are some fillers are available. Fillers. Other is muscle flaps. Why we have to make fillers and muscle flaps? Because opposite lung can herniate to the empty space and it can undergo torsion, it can go on herniation, torsion. So, in order to prevent that, you have to effectively manage the dead space after pneumonectomy. Understood? So, 11th edition of Schwartz says left massive pleural collection, possibly a hemothorax. Early complications include cardiac arrhythmias, especially arterial fibrillation, atrial fibrillation, respiratory failure, bronchopleural fistula. Late complications include empyema, pneumonectomy, syndromes and chest wall deformities. Now tell me, you was a hemothorax and hemopneumothorax was there or only hemothorax was there? Because in the explanation, if this question has been only hemothorax in the option, then hemothorax could be the answer. But air and collection is there, then it would be hemopneumothorax. So based on the question, you will kindly adjust your answer accordingly. Supply to this flap, reconstruction of the breast, and so the right answer is inferior epigastric artery. Okay, inferior epigastric artery is the right answer. You can see the scar here. Okay, deep circumflex iliac artery are very thin flaps, so they don't use that, and it is the inferior epigastric artery is the right answer. Inferior epigastric artery supplies the lower abdominal wall and it is commonly used for flaps. It's called tram flap, transverse rectus abdominis myocutaneous flap. Okay. And when you use inferior epigastric artery, you can use reverse tram. Is also option here. Identify the image shown here. It's a sample image collected from the Google. If suppose it was the same image given in your exam, then say yes. If the same image is there, then what is the abnormality and it is called? The right answer is plagiocephaly. And plagiocephaly refers to the asymmetrical flattening on the one side of the skull, often resulting from external pressure on the infant's head. And this condition is commonly observed in infants who spend a lot of time in lying in their back. Okay, so it's called plagiocephaly. If the same image was given, and this is the answer. A patient was being put on IJV. Patient developed SpO2 drops with BP drops. What is to be done? So, an internal jugular puncture was done. Probably this was the question. And the patient drops saturation and the BP. What could be the cause? And this is a typical case of a air embolism as given in page number vascular access in 20th edition of Bailey. Air embolism can occur during a central vein catheter puncture or placement, and immediate management includes left lateral decubitus view and Trendelenburg procedure to prevent air from entering in the pulmonary circulation, called Doran's maneuver. Is it okay? Left lateral decubitus and Trendelenburg procedure. As given in Bailey, if as given the question in the same way with options. Any doubt? Is it all clear? Shall we move on? Yeah. Now identify the image. Image based question. What is the diagnosis? And diagnosis. Yes, please. So, the CT image shows a thickened pleura. Yes, following a consolidation of empyema. Chest CT and the collapse of lung. And you see a grossly thickened pleura. And the treatment of choice for this patient, if an appropriate, you can see here, if an appropriate drainage has not done, this is the complication occurs. If a hemothorax or pus, thoracic cavity, empyema not drained, and eventually it contracts and collapses the lung. So, the treatment of choice for thickened pleura with empyema is decortication. And after the advent of VATS, it is VATS decortication. VATS decortication could be the treatment of choice. Now, identify and diagnose. So, this is a case of a bronchoscopy. So, in the bronchoscopy, what do you see? This is a tumor and this is located in the central lung, because in the bronchus. Most commonly, it is either squamous cell cancer or small cell cancer. Small cell lung cancer. So, for centrally located cancer, it is a bronchoscopy and biopsy. And contrary to that, peripherally located cancer, the most common peripheral cancer are adenocarcinoma of the lungs. For the adenocarcinoma of the lung, you do transthoracic CT guided biopsy. Is it clear? So, adenocarcinomas are known for the periphery, and squamous cell carcinoma are known commonly occur in the central. You see squamous cell, C, S, so smoking, C, central located and cavitating lesion, and it can produce hypercalcemia. This goes with, same will go for small cell also. Okay, so this is a flexible fiber optic bronchoscope to see the tumor right in the bronchus. And the bronchial carcinoma can also be central lesions. Squamous cell can also be central lesions. Small cell can also be central lesions. Schwartz, leatherization, very clearly says. Okay, now identify the image. Image and diagnosis. What is that you see in LA? In the left atrium, you see something. What is that? This is left atrial myxoma. Left atrial myxoma is the most common cardiac tumor. They'll ask you this question. Most common cardiac tumor and is mostly mobile. And treatment of choice is surgery. Surgical excision, surgical removal. There will be a small stalk. You need to tie it and you need to remove it. Myxoma. Left atrial myxoma is a benign tumor commonly found in the left atrium. It often appears mobile echogenic mass on echocardiography. 21st edition of Subistem. DeBakey type 1 includes aneurysm. What kind of aneurysm? Where it involves? Yes, this is a cardiothoracic surgery. And it's very straightforward, a simple question. The right answer is involvement of the whole aorta, ascending and descending. So, type 1 dissection involves the ascending aorta, arch and the descending. Type 1 is complete. Okay, type 1 is complete. Now, identify this. What is the problem here? It's a congenital heart disease. Congenital heart disease. So, you have a classical transposition of great vessels. Why? See, this is the right atrium, this is the right ventricle. You see aorta taking its origin from right ventricle. This is the left atrium, left ventricle. And you see the pulmonary artery taking its origin from there, pulmonary artery. So, this is TGA. See, atrioventricular concordance. Ventriculo-arterial discordance. Atrioventricular concordance means what? Right atrium opens to right ventricle. But ventriculo-arterial discordance means what? Because the ventricle does not open to the corresponding vessels meant for it. The right ventricle opens for aorta and the left ventricle opens for pulmonary artery. So, it is a ventriculo-arterial discordance. That is the definition actually. TGA, transmission of great vessels, is that the definition is all about. Okay? Do you understand? Yes. There is something called corrected TGA. Corrected TGA. Where atrioventricular discordance and ventriculo-arterial discordance. That means, see this. This is corrected TGA. You should know this also. See what happens, RA opens to LV and LA opens to RV. And RV opens to aorta. And LV opens to PA. So, both are discordant. RA should not open to LV. So, atrioventricular discordance and left ventricle should not open to PA. But left ventricle opens to PA. So, ventriculo-arterial discordance. Both are discordant. But what happens? The deoxygenated blood enters the RA, goes to LV, it goes to PA. Deoxygenated blood ultimately goes to PA only. Similarly, oxygenated blood which comes, yes, to LA, go to RV. But RV in fact opens into aorta, that means oxygenated blood goes to the systemic circulation to aorta only. So, this is called corrected TGA. So, actually the oxygenated blood goes to aorta and deoxygenated blood goes to pulmonary artery. But what happens is, what is the problem here? The appropriate blood goes to the appropriate channels and the systems. But the problem is, the right ventricle cannot handle the systemic circulation and the patient will end up in corrected TGA, especially right ventricular failure and pulmonary hypertension. Is it okay? Hello, have you all understood what I am saying? Say yes or no. So, TGA is an important question in exam. Transposition of great vessels, Bailey 28th edition, page number 944. Characterized by aorta arising from the right ventricle and pulmonary artery arising from the left ventricle, leading to parallel circulation. Identify the image. Showing a massive left atrium. If showing a massive left atrium, it means what? Correct, mitral stenosis. Okay, enlarged LA. So, because of stenotic mitral valve. So, mitral valve has two things, anterior segment and the posterior segment. Anterior is A1, A2, A3. Posterior segment P1, P2 and P3. Anterior wall will be thick. Anterior cusp will be thick than the posterior cusp. Anterior mitral leaflet, very, very important. Okay, especially in HOCM. Anterior mitral leaflet movement across the asymmetrical hypertrophy of the septum in echo is a classical finding on HOCM. So, mitral stenosis causes left atrial enlargement. A 35-year-old female patient, 12 into 8 centimeter lump, mobile, treatment option. So, you see a prominent vein, but axilla to this tumor looks negative, not mentioned in the question, mastectomy. It could be a phylloid tumor. It looks like a phylloid tumor, treated with wide excision of 1 centimeter margin, and local recurrence is common with inadequate margins. So, mastectomy is necessary for very large tumors. Okay, cystosarcoma phylloids. It looks like malignant but actually benign tumor. Cystosarcoma phylloids, because cystosarcoma phylloids will behave locally malignant. Looks like locally malignant. You see the enlargement of veins. It will even cause ulceration because of pressure necrosis of the skin over the tumor. But axillary lymph nodes will be negative, clinically and pathologically. It's called cystosarcoma phylloids. Treatment is mastectomy. Okay, next question. Zaska disease is what? Zaska disease. Z-U-S-K, Zaska disease. It's a very simple and straightforward question. Okay. We have discussed in the class already. The right answer is recurrent subaortic abscess. So, as given in 11th edition of Schwartz, chapter 17 in breast cancer, recurrent periductal abscess and fistula near the areola, sometimes termed as Zaska disease, are usually due to squamous metaplasia of the duct epithelium causing obstruction and secondary infection. So, abscess anywhere in the body, you should do I and D, very important, I and D. So, there will be a pus discharge, What is the CTP score? I told you all scoring systems are very important. 3 to 4 questions will definitely come. CTP scores of bilirubin 3.4, prothrombin 26, mild ascites and albumin 2.9. So, markedly lethargic and drowsy. Finding. The right answer for this patient will be 12. So, according to Child-Turcot's score, okay, and it is Bailey 20th edition, page number 1191. Child-Turcot Puke score is calculated based on the bilirubin levels, prothrombin, time, ascites, albumin levels, encephalopathy, the given provided values. The score is 12, indicating the classification of Child-Turcot Puke score of C is treatment of choice for C will be liver transplantation. The scoring system of liver function. So, liver transplantation. Okay. So, there we go. So, according to me, this paper I have viewed overall, this looks easy to moderate question, and more than 140 questions are available in the app itself. Except for 10 questions, I will tell you which 10 questions after end of my discussion. This is session 1 today. And close to 140 plus questions are easy questions, and all these are well covered in the class. And it is available in Speed Learning app. And you can go back to rest of the chapters and you can just see similar questions are available, and I will be discussing in upcoming week of rest of the sessions also. I am preparing it and I will present to you, and that will be loaded in the app for your future reference in case if you require. Okay, and thank you very much for watching into this video and learning through this class. Thank you very much.